Good morning, everybody. I'm physiotherapist K. Sudarshan, Kasturi College of Physiotherapy Associate Professor and Secretary. I'm going to discuss about rehabilitation for SI joint pain and or its dysfunction. Before going to that, I want to briefly discuss about role of physiotherapy in orthopedics. Physiotherapy is a non-pharmacological, exercise-oriented natural approach and non-separable entity from orthopedics. Physiotherapy can face orthopedic challenges because of its therapeutic, preventive, and restorative functions. All fractures may not need reduction or retention, but all fractures needs rehabilitation. Physiotherapy plays a major role, important role in rehabilitation. See, any trauma can cause injuries to soft tissues, joints, and bones. Soft tissue injuries leads to muscle atrophy, which leads to contractures, results in joint stiffness. The joint injuries directly brings that joints into stiffness, and bone fractures, which requires immobilization for its recovery, results in joint stiffness. Joint stiffness, because of joint stiffness, the functions of that joint is going to be impaired. To restore the functions, we require rehabilitation. Rehabilitation includes prevention of avoidable disabilities like bed sores, venous thrombosis, muscle contractures, muscle atrophy, and joint stiffness. Physiotherapy plays a major role in rehabilitation. See, coming to aims of physiotherapy: to treat, to correct, and to prevent disabilities and deformities, to relieve physical pain, to heal the injuries, to increase strength, to increase balance, balance, to improve coordination, and to enhance cardiopulmonary performance, provides gait training, to train the gait properly, and to postural correction, make the individual independent for his activities of daily living. These are main aims of physiotherapy. Here we are having different options to treat different conditions. We are having our physiotherapy weapons or exercise therapy, electrotherapy, cryotherapy, hydrotherapy, and thermotherapy. These are all different treatment methods to treat different conditions. In our slide, we are having different colors, same like different colors. We are having different treatment methods to treat different conditions. Today's my topic is sacroiliac joint pain or its dysfunction. See, sacroiliac joint pain is commonly described as sacroiliitis and sacroiliac joint dysfunction. Sacroiliac joint dysfunction is a significant source of pain. 15 to 30% of people with mechanical low back pain. It is difficult to diagnose and is often overlooked. Pain can frequently mimic and be misdiagnosed as radicular pain. See, clinically relevant anatomy. If we observe anatomy, it is a plain synovial joint. Even though it is a plain synovial joint, the articular surfaces are having irregularities in the form of elevations and depressions. Multiple structures are involved in supporting to the sacroiliac joint. The major supporting structures are ligaments. They are anterior and posterior sacroiliac ligaments, interosseous ligament, ilio-lumbar ligament, sacrotuberous ligament, and sacrospinous ligament. See, the main function of the pelvic girdle is to provide shock absorption and to transmit forces between upper body and lower limbs, See, coming to etiological factors, we are having different etiological factors. They are broadly categorized into traumatic and non-traumatic and physiological. Traumatic, fallen from heights and road traffic accidents, bike accidents and car accidents, etc. And non-traumatic inflammatory conditions, ankylosing spondylitis, osteoarthritis, and joint infections like brucellosis, tuberculosis, and metabolic disorders are like gout and hyperthyroidism. And physiological condition, pregnancy is a condition where female pregnant women, their sacroiliac joints are going to be affected. The force from injury can strain the ligaments around the joint. Tearing ligaments leads to too much motion in the sacroiliac joint. After fifth decade, the sacroiliac joint is going to be fused. If we observe the epidemiology, approximately 90% of people will at some time they may experience mechanical low back pain. Adult population are more affected. It is seen in more commonly in adult population, and the persons who are having sedentary lifestyle and obese patients, and both the genders are affected. The disorders are seen in all the races. See, clinical presentation. If we observe the signs and symptoms, low back pain, the most common signs and symptoms include low back pain, thigh pain, difficulty sitting for too long time, local tenderness over the PSIS, and pain occurs on the joint. Pain occurs when the joint is mechanically strained, example, forward bending, and apparent sacroiliac movement pattern. The joint can be hyper or hypomobile, which can cause pain. Patients can often complain of sharp stabbing or shooting type of pain down the posterior thigh, radiating down the posterior thigh. And patients will frequently complain of pain while sitting down, lying on ipsilateral side of pain, and climbing stairs. Coming to differential diagnosis, the differential diagnosis should include radicular pain, piriformis syndrome, ankylosing spondylitis, lumbosacral facet syndrome, spondyloarthropathy, trochanteric bursitis, hip fractures, hip overuse syndrome. See, coming to diagnosis, the patient hip should be evaluated for symptoms elicitation, range of motion should be performed, Trendelenburg testing is helpful, direct palpation over SI joint leads to the pain, leg length should be measured in all patients. Coming to physiotherapy assessment, physiotherapists use a variety of orthopedic provocation tests. First one is Eamon's test. The patient is in prone position with the knee flexed to 90 degrees. The examiner raises the flexed leg off the examining table, hyperextending the hip. This test places stress on posterior structures and anterior structures, anterior sacroiliac ligaments. The pain suggests a positive test. And next, Gillette test. The examiner thumbs placed under the posterior superior iliac spine and S2. Patient is asked to stand on one leg and the other leg is moving towards the chest. If the joint side that is flexed moves up, joint side that is flexed moves up, that indicates the positive test. And other test is Lagrange test. The patient lies supine and the examiner flexes, abducts and rotates the patient affected joint. The pelvis must be stabilized and pain signifies a positive test. This test differentiate hip pain from sacroiliac joint pain. And the next is sacroiliac compression test. The patient lies in supine position. The therapist with his crossed hands applying pressure over anterior superior iliac spines, anterior superior iliac spines. By applying the pressure, we are if the patient gets pain, that is strained anterior sacroiliac ligaments, that is positive. If we get the pain, that is positive. Pain is a sign of strained anterior sacroiliac ligaments. And last test is Faber's test, flexion, abduction, and external rotation. These three movements combined result in clinical pain provocation test to assist in diagnosis of pathologies at hip, lumbar, and sacroiliac joints. Often, CT scan and MRI are used to diagnose perfectly. Physiotherapy management. To reduce pain, we will use electrotherapy modalities like ultrasound therapy, TENS, and IFT. To reduce inflammation, we have cryotherapy techniques. To improve mobility and stability, we will perform exercises. See, core stability exercises. We are having two important core stabilizers. They are the transversus abdominis and lumbar multifidi. These two are the two important core stabilizers. Isometric exercises of these muscles improves the stability. Isolated lumbar muscle training. These exercises performed in sitting or standing, the muscles which are below the umbilicus, they are contracted isometrically. Controlled respiratory pattern is used. After one inspiration and expiration, we will perform isometric contraction of muscles below the umbilicus, which activates the core stabilizers. Along with that, we will use the quadruped position. In quadruped position, the patient slowly raises one hand, which activates and stabilizes the core stabilizers. And next is integration of stabilization into light dynamic functional tasks. These exercises performed to improve lumbopelvic control, in which co-contraction of transversus abdominis and lumbar multifidi. Hip extension, lumbar spine extension, thoracic spine extension, exercise is performed along with co-contraction of core stabilizers. This improves the dynamic function of lumbar pelvic girdle, dynamic function of pelvic girdle, and integration of lumbar stabilization into heavy load dynamic function tasks. These exercises are isometric co-contractions to be performed with addition of heavier external loads to the lumbar spine. To increase the complexity and the load of these exercises, single leg and bilateral bridging exercises of lower limbs is performed in an unstable surface such as Swiss ball. These improves coordination and balance. See, coming to manipulations, manipulation therapy, manual therapy techniques reduces the pain and functional disability. First one is SI joint manipulation. The patient lie on his back with the therapist standing opposite the side to be manipulated. The patient places his hand behind his head and the therapist then moves the patient passively into side bending to end range towards the target side. The therapist then applies a quick thrust to the anterior superior iliac spine in a posterior and inferior direction. That is SI joint manipulation. Lumbar rotational manipulation. The patient lies on unaffected side and therapist stands opposite the patient, flexing patient's hip until the lumbar spine is in flexion. The therapist grasps the patient's lower shoulder and arm to stabilize him and moves him into left trunk side bending and right rotation until motion is felt at the desired segment of the lumbar spine. The arms of the patient are placed on the therapist arms. The position is maintained while the patient is rolled towards the therapist. The therapist's other arm is used to apply high velocity, low amplitude thrust to the pelvis in an anterior direction. Posterior iliac rotation sacroiliac joint manipulation is another manipulation technique to manipulate an anterior iliac rotation displacement and to restore posterior iliac rotation displacement. We will use this manipulation. The patient lies on his side and towards the therapist. The therapist places his hand on the ASIS and the other hand is on ischial tuberosity. The top hip is flexed to 90 degrees and the other leg is relatively in extending position. Pull the patient's bottom arm in anterior and superior direction. The hand on the ASIS pushes posteriorly and the hand on other ischial tuberosity pushes anteriorly. This must be maintained for 10 to 30 seconds. Anterior iliac rotation sacroiliac joint manipulation. The aim is to manipulate posterior iliac rotation displacement and to restore anterior iliac rotation. See, the patient lies prone with a pillow under his pelvis. The therapist supports the thigh just above the knee. To stabilize the ilium, the other hand is on ipsilateral PSIS, pushing in an anterolateral direction. The therapist finger should be pointed towards the patient's foot. After positioning, the therapist brings the leg above the table into hip extension just enough to take up the slack in hip flexors. It is recommended to hold this position for 10 seconds with knee either extended or flexed. See, coming to stabilization, commonly we will use a pelvic belt. High position is more effective than low position. That is just below the ASIS. Low position is on the pubic symphysis. Coming to hypermobile SI joint, pelvic belt is more appropriate. It should be worn for 24 hours per day up to 6 to 12 weeks. Belt should be used in combination with physical exercises and manual therapy in case of joint dysfunction and muscle imbalance. The belt may be removed once the patient has improved control of the lumbopelvic musculature. Surgery is the last resort and is not always associated with good outcomes. SI joint activities to avoid when sacroiliac joint pain is present. All dynamic functional activities should be avoided, such as playing games, sports, and exercises like weightlifting, crunches, biking. All these works we should be avoided. References. I collected this information from Physiopedia websites, physiopedia.com, spinehealth.com, and few articles, Slipman and Monticone and Norris, who presented articles. their articles. Thanks for giving this opportunity for me and encouraging me. Thanks a lot. Thank you.